A very good morning to all of you. We warmly welcome you for today's CPD program webinar organized for the GMOA members by the Government Medical Officers Association and Society for Health Research and Innovation. Let me get to the same housekeeping rules as usual. The webinar link will be available from 9 a.m. to 9:45, 9:50 a.m. for you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCC PD guidelines. I would ask you to kindly switch off your video and mute your microphones so to stop any disturbance during this webinar. And also, I would invite all of you to type in any of your queries within the chat box to be discussed at the end of the session. So without further ado, I would like to introduce to you Dr. Himal Kalambarachi, who is the consultant physician at Base Hospital Mahaoya, to introduce to you today's topic and today's distinguished speaker. Thank you.
Thank you, Dr. Romali. Very good morning to everyone, and I'd like to wish you a very happy new year. This is our first webinar in 2022, and I warmly welcome you all who has joined with us most precious weekend and holiday with us to listen to our topic. So today's topic is kind of very important to us. We select this topic. This is important to every aspect of our specialties. It is regarding clinical audit. So this subject we need to improve our quality of care, the best patient care for everyone. So assess how our system runs so far and what we need to do in future. So to deliver this precious topic, we have our guest lecturer, Dr. Sathyajith Ambawatte, who's an acting consultant physician in Ministry of Health. Currently, he is working as neuromuscular fellow, St. John's Hospital, London, UK. He's not a stranger for neurology society and neurology colleges, and he has a lot of publications, over 20 publications under his belt regarding research. And recently he has done quite a high number of clinical audits in Sri Lanka as well as in UK. I would like to invite Dr. Sathyajith to join us and to deliver his talk. And he's joining us with this, all the way from UK to entertain us and deliver this talk. Dr. Sathyajith, session is over to you.
Thank you. Can you hear me?
Yes.
Can you see my slides as well?
Yes, we can see.
Right. Okay. Thank you for the nice introduction, Himal. So I am Sathyajith Ambawatte. So I will discuss mainly about these clinical audits and as a clinician, how to execute and present your clinical audit and some practical tips as well. So my outline is few words about clinical governance, maybe a bit new topic as well. And what is clinical audit, followed by history of clinical audit as well. Then some differences between clinical audit and research. Then the steps of clinical audit, that is audit cycle. And few words on confidentiality and ethics as well. Followed by, I will show you one of my presentations on clinical audits, clinical audit, one of my audit, and the practical tips and stepwise explanation as well. I have no disclosures. So why should we do clinical audits? So, I mean, we have to improve ourselves. I mean, our team and your practice and your local practice should be improved, and we should be humble enough to assess your own practice and your own team's practice and your own hospital's practice, and to make changes to improve our standards. And first of all, to do that, you should be humble enough to identify your faults and where we can improve ourselves as well. So it's the best way to assess your own clinical practice and to improve your own standards as well, and to improve your own patient care and your local patient care. And the next thing is your CV. Previously, a few years ago, they were just looking after researchers, but nowadays they ask for clinical audits as well. They especially in foreign countries, the recommendation is to do at least 2 audits per year and to complete at least 2 audits within 5 years or so. So it is very important to do medical clinical audits, and it is important for your CV as well. You can include your CV, and by doing clinical audits, it will make a good impact on your CV. And then if you're planning to go abroad or foreign training or just to go abroad, so in those job interviews, they will ask a few questions on clinical audits. So something about audit cycle and your practical experience and how you improve your system as well. So recently it has been a compulsory question for most of the job interviews. And when if you're planning to go for a foreign training, then it is a compulsory question as well. So that's why it's very important to know. Few words about clinical governance. This may be a bit new thing, so I'll just tell you the definitions, framework of health system organizations, and which is accountable for continually improving the quality of their services and safeguarding high standards. This is, nobody will ask this definition unless you will come into medicine. But in most of the interviews, they will ask about these 7 pillars of clinical governance. It is mainly relevant to the UK system, but we can use this system to our system as well. So there are a few pillars, 7 in number. Like out of those, clinical audit is one of them, and clinical audit is one of them. Others are clinical effectiveness, risk management, use of information, education and training, and staff management, followed by career experience and involvement. So clinical audit is that important in the system to improve ourselves and the system. What is a clinical audit? Before that, if you want to start a clinical audit, if you start reading, you will come across few words like audit, quality improvement project, research, surveys, system evaluation, those kind of things. So I will just briefly tell you what is a clinical audit. But first question is clinical audit the same as quality improvement project? So more or less it's the same, but when it comes to clinical audits, we mainly discuss about the clinical stuff. But when it comes to quality, it may be clinical, it may not be clinical as well. For an example, so like availability of hot drinks in A&E, it may not be clinically relevant, but may be relevant to improve the hospital system depending on the circumstances. So, but what you do is almost the same. So that's why I'm saying it's almost the same. And not all audits are clinical audits, because audit is a general term that we can use in financial audits and managing audits, and there are different types of audits, but clinical audit is one of them. We assess our clinical stuff. Then the definition is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria, where indicated changes are implemented and further monitoring is used to confirm improvement in healthcare. I'll go through this definition to break down this, to have a better understanding. So a quality improvement process. So it's straightforward. So we are doing an audit to improve the quality. So the question is of what? So to improve patient care and outcomes. So that is clear as well. Then the next thing is through systematic review of care against explicit criteria. That means, so after selecting a topic, so you have to go through the guidelines and the recommendations. So after you select those guidelines, which is suitable for your setting or your hospital, you have to compare your practice against that criteria. So that's the main reason why we do the audit. And then after you, collect data, analyze the data, then you will find out that there are certain things that you can be improved in your system. Then you have to make some changes and implement them. And the final thing is the further monitoring is used to confirm improvement. That means after implementing those changes, we have to reanalyze or collect data again and reanalyze and see whether your interventions are successful or not. And this should be done continuously. So that is the basic idea of clinical audit. And few words about history of clinical audits. Who did the first clinical audit? Anyone has any idea? So the first full clinical audit was done by Florence Nightingale in 1853 during the Crimean War, where they found that there is increased deaths in the war zone. So then they improved the sanitary conditions, and they did another audit after that, re-audit after that. So they found that the mortality rate was 40% before improvement of sanitary conditions, and after that it improved to 2%. And the documentation of the clinical audits goes back to 1750 BC. During the period of King Hammurabi as well, where he instigated audit for clinicians by instructing them to do the clinical audits. But there are no exact details and specific details whether to say that they completed a full audit. But the full documented full audit is done by Florence Nightingale. And who are the forefathers of clinical audit? Bit of theory, maybe a bit boring as well. So Ernst Codman, an orthopedic surgeon at Harvard Medical School, monitored surgical outcome in 1912, and Dr. Avedis Donavedian in 1966 proposed his conceptual model, still used in some definitions of clinical audit, that is structure, process, and outcome. However, medical audit undertaken by doctors was first formalized in 1989. Few words on history. And what are the differences between clinical audit and research? So research is concerned with discovering the right thing to do. Audit is with ensuring that is done right. That means research is done to identify or to discover new knowledge, and after we discover new knowledge, our main target is to practice that. So audit is to ensure that we practice that. There are a few things that we should know. So clinical audit is done to evaluate how close our practice is to best practice. Best practice is the recommendation. So research is to establish what is best practice. So the clinical guidelines are mainly based on research and expert opinion. And then again, clinical audit is relevant mostly to the local setting by saying that. So if we do a local audit, the changes that we implement, the deficits that we find in our system is relevant for your system. So it may not be relevant to another hospital or another country. But when it comes to research, for an example, we treat myocardial infarction with aspirin according to research. So we can use aspirin all over the world. So it can be generalized. So that's one of the main differences. And in clinical audit, our main aim to improve services. With research, we generate new knowledge, as I already mentioned. And usually the clinical audit is led by service providers, that means clinicians. And research is done by researchers. And clinical audit is mainly practice-based and usually done during a short duration, depending on the topic. And research is often theory-driven. Clinical audit is, again, ongoing process, and research is done on and off. And Usually randomization, placebo treatment, and complete new treatment is not studied involved in clinical audit. In research, we may use it, but when it comes to sampling, we might have to randomize, use random sampling when we select the sample, just to reduce the bias. So what is service evaluation? As I mentioned you earlier, so you will come across few terms if you read along this topic, like clinical audit, quality improvement project, research, survey, service evaluation. So this is out of the scope of this topic, but just if you're curious, you can read on this. Then the main stages of clinical audit. So there are a few stages. So we call it audit cycle. This is a very hot topic these days in a lot of job interviews. It is like a compulsory question. So they will ask about this cycle, and they will ask few experiences of your own, and what are the outcomes of your clinical audit, and how they improve the system while doing this clinical audit. So it's like a compulsory question these days. So first thing is to identify a problem. Then you have to define the standards, followed by data collection and analysis. Then you have to implement changes and re-audit. Even though it looks like a bit of simple thing, it is definitely easier than a research. But there are a few things in between these cells as well. So I'll go through it step by step. First thing is selecting a topic. So that is basically identifying a problem. So you have to work in the hospital and then identify what are the things that we can improve and what is relevant for your local hospital, what is relevant for your hospital or system. Then you have to select a topic. So it should be very important, otherwise no point of doing this audit. Then agreeing standards of best practice, that is the second thing, definition of standards. That means after you select a topic, for an example, if you try to do an audit on management of how you manage your patients of myocardial infarction, acute coronary syndrome kind of thing, then you have to go through the guidelines which is relevant for myocardial infarction, and then you have to choose what is more relevant for your local practice. Like if you have a CCP guideline, that is more relevant. If you have a local hospital guideline, that should be more relevant than using an international guideline. But if you don't have an international guideline, then you can, or your local guidelines, then you can choose an international guideline. And if you don't have an international guideline, there are guidelines called consensus guidelines. That means there are those are guidelines published by using a lot of experts of this field as recommendations. So you can use that as a standard as well. Depending on your topic, you have to choose these standards. Then you have to collect your data, then analyze your data against those standards. Then the next thing is implementing the agreed changes after analyzing the data. Then you have to do this re-audit, that is collecting the second set of data and analyze and give a feedback and discuss your improvement. But there are a few things in between as well in the process, because after you collect the first set of data and analyze it, you have to present and discuss among your team and among your system. And then we have to make the changes. So after you analyze your data against standards, it's better to feedback the results to your team, and then they will get to know that how we are doing at the moment. And we have to discuss with them the possible changes. So if you discuss among your team and all the experts, then they will come up with bright ideas, and which will be very useful to improve our standards. So that discussion is crucial. And the questions during your presentation after your first data analysis is very important to improve the standards and implement the changes. And then after you make the changes, you have to give some time, because they have to get used to this new system. No point of doing the re-audit as soon as you're implementing the changes. So it's kind of a behavioral change, everything. So you need some time. So you have to give enough time before re-auditing. So after that, you can re-audit and then give feedback and discuss the improvement. Few words on confidentiality and ethics. So the most important thing is, we don't have to go through the formal ethical approval as we go through when we are doing research. But the basic principles you have to maintain, like confidentiality and disclosure of audit results as well. So the basic concepts are there, but you don't have to take a formal ethical approval. Then it comes to data protection. You have to be accurate and we have to collect all the relevant data, but you don't have to collect excessive data. And then it is only used for your audit purpose, and you should be keeping those data only for the relevant period. You don't have to keep you can't keep those data for a long period of time. And it should be kept in a secure place. So in most of the developed countries, all doctors are given an official email and official system as well. So if you haven't anonymized the data, they recommend to use your official email and the official system. If you use your personal emails like Gmail, Yahoo, whatever, then if there is a data leak, you will be responsible for that. But in Sri Lanka, we don't have official emails. Unfortunately, we have to use those things. But if you're using this, better to anonymize all the data, so then you can't identify the personal details of the patient. And the next thing is Caldecott Code principle. So patient identifiable information must only be transferred for justifiable purpose. So for an example, I will go back to the same example. So if you collect data on management of acute coronary syndrome, so if you identify there are about 10 patients who are not on aspirin without a contraindication or allergy, then it is justifiable to divulge that information to improve that patient's management. So if it is justifiable, you can do that. And in developed countries, there is a Caldecott guardian as well who will facilitate this thing, because then if the patient is still under us, then we can just inform them. But if the patient is not under the same system, then or the same hospital, then we can use the help of Caldecott guardian. Then how to start a clinical audit? So I am mainly discussing what is practical as a clinician. So usually you should have a good team, and also I recommend to have one colleague from community medicine team as well, who will help you with statistics and the methods as well. So after that, but the procedure varies greatly from one hospital to another. So what I recommend is go to the management team or the administration and ask whether there's a standard procedure of clinical audit. Usually if they are clueless, that means there is no standard procedure usually. So if that is the case, you can discuss among your colleagues in the system and you can start your audit. But usually in most of the hospitals, where there is a system, they ask for something called audit proposal. If they have a system, if they want an audit proposal, they will usually have a standard form. So I have gone through a lot of audit proposal forms. They more or less ask about the audit cycle, the details of the audit cycle, then time frame and all. But the form structure may differ from one hospital to another hospital. So depending on the form structure, you have to fill the relevant data. Then you have to give it to the audit team. So in most of the hospitals in the UK, they have a team where they have a diary of clinical audit. So if you're planning to do a clinical audit which has been already done recently, then they will tell you no point of doing that. And sometimes they will facilitate the audit, especially when it comes to data collection, especially if there is a data collection, database, they will help you to do that. But if you don't have a database, then you have to collect full data the whole data from scratch, and then you can start the clinical audit. So the basic thing is, if you have a system, then use that system. If you don't have a system, just go through the principles and you can start the audit. And few practical tips. So we do researchers, maybe you're interested in that topic, or maybe for research relevance, or maybe you are doing a PG. So if you're starting this process as a new thing, it's always better to start which is related to your research, because then it's easy to do. And the next thing is start with a simple thing. It's no point of doing a simple thing but with no importance, but you have to identify what is important and then start a simple audit, which is the best way to start. After that, you can do some complicated audits. Then always think about re-audit. So the problem is, so if you choose a rare condition, then to have a better sample, you have to wait for a long period of time. As I mentioned you earlier, after you analyze the initial data, after you implement the changes, you have to wait for a longer period of time if that is a rare condition as well. Then by the time you are planning to do the re-audit, you may be working in another hospital, you may be in another country, so we don't know. So always think about the re-audit, because no point of starting an audit if you are not going to complete it with a re-audit. So always keep that in mind. So the main and the other tip, as I told you earlier, as clinicians, it's better to have a colleague who knows statistics and community medicine, one of the community medicine colleague as well. So then it's easy to carry on with the audit. Then I will go through my first audit presentation and I will explain stepwise manner, so to have a better idea. So this is my first audit. So I started related to my research, and I started as a simple thing. So, and I always thought about the re-audit before this audit. So this is the audit cycle. The first thing is to select a topic. And with that, I will go through the audit presentation as well. So this is my topic, because I did research on acute stroke patients. So I choose a relevant topic to my research, which is important and which is easy to do. So the topic was clinical documentation in acute stroke patients in teaching hospital. So when you're presenting this audit, there are two things. So one is clinical documentation and one thing is acute stroke in this hospital. So I gave a few words about acute stroke management in this hospital, and how we manage, how we do the acute care and follow up, and how we find the etiology as well. So then few words about clinical documentation. I went through this BMJ Carrier, so the 14 article, and I mentioned a few important statements in that article to emphasize the importance of clinical documentation. Then the next thing is to define the standards. So I went through the guidelines of stroke management, especially acute care. There were 3 guidelines at that point: 2017 CCP guidelines, 2008 NICE guidelines, and 2018 AHA guidelines. When it comes to documentation, these 3 guidelines are almost the same. So this is my standard. So I went through it. So when it comes to documentation, we have to document all the important aspects. So that is the recommendation. Then collecting the data. So I collected my data on clinical documentation mainly on 4 topics: that is presentation, time of onset and symptoms, and comorbidities and risk factors. And the third one, severity assessment using the specific criteria for stroke. and then the pre-stroke disability assessment using modified ranking scale. So I have a good structure in this one. So there is a clear data collection plan under 4 different topics, which is relevant for this audit, and in back of my mind, it is relevant for my research as well. And then is analyzing data against standards. So there are 46 patients. And so I've given the data that I found after the initial assessment, initial collection of data, how many people have been having, the complete documentation and symptom analysis, date of onset and time of onset. And it's always better to compare with a standard care practice in hospital. So I compared these findings with another hospital in London. So it is always motivating when you compare with them, because they have documented all the things. We're closing 100%, but we are somewhere below. So if they can document this, why we can't document it? So it's always motivating to go through a better hospital. So by doing that, we can make the changes and then do the re-audit. So because it's documentation, you don't need CT, you don't need MRI. It's just documentation. So then I went through the comorbidities. This is my second topic, data collection topic. So what are the comorbidities? Have they documented all those things, and have they gone through all the risk factors which is relevant for stroke? And then the assessment scales, GCS, have they used the GCS score, and how much of people and what is the percentage they have used the NIHS score, which is the standard recommendation in CCP guidelines and AHNI's guidelines. Then the pre-stroke disability assessment, where they have assessed the pre-stroke functional status, and out of the people they have assessed the functional status, have they used this MRS score, which is the recommendation. So I have gone through all these 4 sub data collection headings. Then it's easy to give the reflection on your data interpretation as well. So then the next thing is feedback results. So in my presentation, I gave a summary. Again, I have 4 main topics which I included in the methods. So that is presentation, comorbidities and risk factors, severity assessment, and pre-stroke disability assessment. So I have given the the percentages, which is important as a summary. Then you can always keep that in mind when we re-audit these patients after analysis. So there is a clear structure where I have used different subheadings in data collection. Then for most of the audits, there may be limitations. So I didn't collect the documentation according to the seniority of the doctor. So there may be house officers, senior house officers, registrars, senior registrars who may be documenting these important clinical data. So if I have analyzed the data, by breaking down according to the seniority of the doctor, the findings may be different. So for junior doctors, they may be missing certain documentation. Likewise, the senior doctors may be missing certain documentation as well. So I don't know about that. So that is a limitation. Always put a limitation if it is there. Otherwise, yeah, you don't have to put a limitation. Then the next thing is discussing possible changes. After discussing among the team and the audience, so we introduce a checklist of documentation documentation and increase the awareness about these specific scores, which is relevant for stroke management, NIHS and MRS scores. So then for implementation, I gave a checklist, so which is more or less similar to my research data collection sheet. So then they know what to collect, what is relevant, and what is the recommendation. So I have included all the things which is recommended in the guidelines. Then I gave the documentation or the collection form of NIHS score and MRS score, which is relevant for this specific topic. And then I introduced mobile apps, because nowadays they have mobile apps for anything, not for this data collection of risk factors and all those things, but for NHS score and standard scores, they have now mobile apps. Always they can use it and they can put the figure, their documentation. Then the next thing is allow some time to change the practice. Then I did the re-audit. There were 42 patients. And then feedback re-audit results. The next thing. So always compare with the previous pre-intervention data to the post-intervention data. And you can always use the statistical methods to compare between the pre-intervention and post-intervention. I've not gone through the details of this analysis and statistical analysis. For that, as I told you earlier, it's always better to have a community medicine colleague if you're a clinician, if you're not sure what you are doing, what you're planning to do with your data. So, and always have a relationship with them and have a good statistical analysis to emphasize the improvement or whether they have not improved after the interventions. So, and compare all the subheadings as well, which is very important. And in risk factors also, I have given through a bar chart, so whether we have improved the practice after the intervention or not. So all things which we audit in before the intervention should be audited again. And then analyzed and have a statistical analysis as well, how we are improving this system. Then the GCS documentation and NHS score, even after intervention, even though there is an improvement, still below 50%. So for that, you have to have a statistical analysis using the relevant method, and publish it as well in the presentation. And then results in pre-stroke disability. So this is mostly rewarding, that the MRS score, use of MRS score was 100% in this set of post-analysis. So that means once they know the system and once they realize it is easy to do that, then they will document it. And then the final thing is discuss whether this practice has improved or not. So the summary of your topic, basically you can give as overall documentation has improved, but NIH score wise, it should have been improved further. So we have to think about how to improve this NIH's documentation and use of NIHS score further. So that is the basic summary. So I have done a few audits just to give an idea what are the topics that we can give. This is relevant for my field. So I retrospectively analyzed few patients, I mean, the clinic patients of who come to our hospital. This one I did when I was in Sri Lanka for Botox injections. So again, I collected what are the demographics of that clinic, the clinic population, and then I collected the data on the indication of botulinum toxin, and I went through the standards of this botulinum toxin injections, and all those guidelines they have recommended to use a follow-up. I mean the functional level of those patients. So there are certain scores. So I found out that they doesn't use those scores. So they just go through the patient's words whether they have improved after the Botox or not. And the other thing is where to give Botox, you have to have enough amount of Botox. So you should be ordering enough Botox. So to do that, we should be knowing how many patients are there. So what are the units that we're needing? So to do that, we should know all the patients that we have. So all the things were analyzed, and then we identified few problems like documentation of the standards, I mean the scores, and but not knowing the exact amount of patients that we are going to deal with, and all those things were handled. And I conducted a Botox injection seminar kind of a thing to improve the dosing as well as the techniques with the help of my consultants those days. And after that, we did an audit, so which gave promising results. And this one I did in my current hospital, a retrospective analysis of shunts of IIH. So this is a big audit. I had to go through about 2,000 patient entries, because in this one, I can't do the re-audit. That's what I'm telling. So you have to decide when you're selecting the audit about re-audit as well, because shunting for IIH is rare. And after going through this, we recommended further to go away from shunting. So to do a re-audit, it will take more longer time. So for this one, I haven't done the re-audit. I have done the audit and I have changed the practice. And again, I did one on management and follow-up of myotonic dystrophica. So here, they don't have an international standard guidelines. For that, I used a consensus guidelines with the new therapy methods and all, because if you don't have a specific international guideline which is up to date, then you can use the consensus guidelines or your local guidelines. Then I did one in the wrist revamp treatment. So this is something new. So they recommend to use in multiple system atrophy patients. So I used the recommended guidelines and I assessed those patients as well. So likewise, there are a lot of topics that you can use depending on your experience and depending on your interest. And the next thing, so some people were asking what is the exact sample size we use. So the thing is, we take this as a snapshot of your practice, and ideally, most of the audits they collect between 25 to 50, but depending on the population and depending on the frequency that you get those patients, there are certain sample calculating formulas where you can use. In our hospital, there is a sample calculating table. We can always use that table to think about the sampling. And then the other thing is, because you are trying to audit your practice and your colleagues' practice, I mean your team's practice. So there may be a bias. So for an example, I will go through the previous example again, like acute coronary syndrome management. So maybe there are 4 cardiologists. So you have to try to include all 4 cardiologists and try to include all similar number of patients. Or depending on the frequency that they see the patients, you use the sampling. And sometimes they may be not filling the forms and all, then there will be bias. So then it's difficult sometimes, especially if you are planning to do a prospective audit. So that means you are doing an audit while practicing that means you are not looking back at the data and then analyzing. So especially when we are doing a prospective analysis kind of a thing, then there may be a bit of audit, because you are analyzing your own practice and nobody is willing. If you're humble enough, if you want to improve yourself in your practice, then it's fine. But some people, especially who are thinking that they are doing the best thing and having a good, bad ego, and they are thinking they are the best, then it's difficult to do audits. So always have have a good mind and be humble to assess your practice, your team's practice, and to improve patient care, then you can carry on with audits. I'll go through with the questions that I gave Himal. So this one, you know the answer, who did the first clinical audit. I'm not going to go through it in detail. And regarding clinical audit, identify the false statements. So the first one, I mean, clinical audit is quality improvement process. So that's the part of definition that's true, and used to improve patient care and outcomes through systematic review against explicit criteria. So that means we are analyzing against standards. So this is also correct. And this medical audit undertaken by doctors was first formalized in 1989. So I have mentioned the details in the particular slide of history of clinical audit, and addresses clearly defined questions by hypothesis using systematic process. So we don't use hypothesis in clinical audit. So that is something to do with research. So we don't create new knowledge by doing a clinical audit. So that is something to do with research. So that is not relevant for clinical audit. And clinical audit is not data collection exercise. So that is basic. That is a basic idea. That's why I introduce this audit cycle, because data collection is only one thing in the audit cycle, because we have to select a topic and set some standards and collect data, analyze data, and implement the changes and give some time and reanalyze. So this is the whole process of clinical audit. So it's just not collection of data. So in surveys and we can just collect data. So what are the components of audit cycle? I went through the audit cycle again, and I'm going to highlight again. So the first thing is to select a topic, then read around the topic and go through the guidelines and set your standards. Then the next thing is to collect the data according to the subheadings, and then analyze the data against the standards. Then what you have to do is present those data to your team and discuss among them and discuss among experts and think about the changes and implement those changes. Then you have to provide some material and you have to give some time to change the system. Then you have to reanalyze it. So that is basically the audit cycle. And the next thing is, what is the components of clinical governance? So it's, as I told you earlier, it is important mainly if you are planning to sit for a job interview in another country, or if you're planning to do postgraduate exam. Sometimes it may be asked in your vivas. So there are 7 pillars in clinical governance. So you have to go through the 7 pillars. And if you read along this topic, there are certain points under each pillar that you should be knowing and you should be practicing to improve the practice and safety of patient care. And the next thing is regarding clinical audits, what are the true things and what are the false things? So re-auditing is essential, yeah. Re-auditing is essential, otherwise it's not complete. So as I told you earlier, so in most of the developed countries, so they recommend at least to start 2 audits per year and to complete 2 audits within 5 years. So that is the recommended training recommendation as well. But it may be different from one specialty to other specialty, and maybe different from one hospital to another hospital. But that is the rate of audits that they're doing at the moment. So by doing that, they know that they have improved their standards. So it's important to do the audits, and always keep in mind regarding re-audit. So the 2 audits that you should complete within 5 years in these countries, that means you have to do the re-audit and publish the data to your local forum as well. So with regards to publishing, so some people are interested in publishing those data. So if you do a local audit, it's better to publish those data in your local forums. And if you do a national audit, yes, you can publish in national forums. Likewise, depending on your data and depending on the significance, you can decide on the publication as well. So there's a nice article in BMJ Carriers. If I can remember it correctly, it was published in 2017. So on how to publish audit. So they have given a nice brief account how to publish an audit as well. So basically, if it is local, then you have to think of some publishing it locally, and if it is national, you have to think of publishing nationally. As I told you in the research slide, if it is not related to, so we don't create new knowledge, so you can't generalize your findings of your audit to the world. So it is mostly relevant to your hospital or your setting. And then the second stem is audit and quality improvement projects are essentially the same. I told you, so it's essentially the same thing. But quality improvement projects can be directed towards non-clinical stuff as well. And modern clinical audits can only be performed by doctors. No, that is wrong. So all service providers can do their audits, like doctors, nurses, therapists, physiotherapists, all the therapists and all the service providers can do their own clinical audits. Next one is not all audit is clinical audit. Yeah, that's true. There are different types of other audits, and it creates new knowledge. So that is something to do with research. So that is basically it. I'm happy to answer any questions if you have any questions.
Yes, Dr. Sathyajith Ambawatte, thank you for the excellent elaboration regarding clinical audits. I myself learn a lot. Since we have advanced time left, so we can go for more questions. So we'll start with the pre-registration question first. What is the minimal sample size for an audit?
Yeah, so that's why I mentioned. So usually most of the audits that have involved, so usually they recommend a snapshot of your sample. So then mostly it will come around 25 to 50, but depending on the abundance of the the selected topic, that's why I told you. So there is a standard sample calculation method you can use. So what we use there is a standard table that we can use in clinical for the sample selection. So depending on that, you can select on the sample. And again, when you're selecting the sample, always think about the re-audit as well, and how long will it take to collect that particular amount of sample as well. So that is the basic way to select the sample. So there are certain calculations we can use. That's why I always mention. So as a clinical and as a clinician, it's always better to have a community medicine colleague who will help with the specific details. Then it is your process will be smoothly driven. So that's my advice on that.
A lot of questions coming through the line of publishing the data.
Yeah.
Dr. Sathyajith, can we publish these data very sensitive and medically related to the patient's personal details? Can we publish without ethical review or ethical approval?
So the basic concept of medical and clinical audit is we don't have to have a formal ethical clearance when it comes to publication. So we have anonymized the patient data. Then what we usually do is when they have a proper system or an established system of clinical audit, then they have dedicated forums for clinical audit presentation. So for an example, in my current hospital, they have mortality and morbidity meeting. So in that they have allowed to present all those clinical audits quarterly. That means once in 4 months they gather and they will present their clinical audits. And if there are large audits that they use large number of patients, there are grand rounds that we can present. So the problem in Sri Lanka is the system is not established properly. So it may be challenging, But there are meetings, and there are meetings to improve standards. In those meetings, you can discuss among the team, and then you can publish those data. So you can publish those data. There is no issue because we are not using the patient identification details.
Right. What is the difference between clinical trial and post-hoc analysis of its and re-audit?
Clinical trials, so that that is something to do with research, and so to identify new knowledge. So if you go through the table that I gave you, there's a nice comparison. What are the differences between research and audit? So clinical trial is a type of research that we use to maybe new treatment to a specific disease. So that is something that we use to identify new knowledge which is not relevant for clinical audit. So clinical audit is something that we use to improve our standards. So re-audit means after we implement the changes, we check out that we have improved our clinical practice. That's basically it. We don't think about clinical trials in this context.
There's a question coming through the message chat box. What is the 2 completed cycles of a single audit?
So that means, first of all, as I mentioned you in the audit cycle, first of all, you have to select the topic and standards and collect data and analyze data. That is the first cycle. Then after changing the practice, then you have to again select the sample and collect the data and again reanalyze. So that is the second thing so that we do. Then you have to compare those two outcomes, and then you have to publish. Present in your whatever the meeting that you're planning to present.
Next question is how to arrange a clinical audit in a various setup in absence of set of guideline of management in most diseases, as well as same time we need to answer how to conduct a clinical audit in a general practice.
Yeah, I have explained these things in my presentation. So Hima, can you again tell me the first question?
First question is how to arrange a clinical audit in a various setup in healthcare setting like Sri Lanka in absence of set of guideline.
Yeah.
Example is a general practice.
Yeah. So there are guidelines. So in the absence of standard guidelines or international guidelines, there are consensus guidelines that we can use. Then if you don't have consensus guidelines, then always better to have stakeholders and discuss about the standards that we are planning to achieve and what are the practical achievable standard. And then always you can decide on that. Then you can compare after collecting the data that whether you have achieved those standards. So yes, practically sometimes you don't have international guidelines. Then if you do a careful literature survey, you will find out that there are consensus guidelines in most of the areas. But if you still don't have guidelines, it's always better to discuss among the experts and then create a standard. Then you can use that standard for your audit. What is the second one?
Second one, the approach in general practice.
Yeah, so it's the same thing. So then if you're the only doctor, if you want to improve your standards, so then you can use there are general practice guidelines as well you can use. Then you have to collect the data and then analyze the same thing as we do in hospitals. Still, you can use it to improve your practice, and you can make some changes to improve your practice. It is still possible, and there are in UK GP setup, they use a lot of clinical audits as well when it comes to patient admission and post-admission care and follow-up, all those things. We can use those things.
There's another question coming through the chat box. What is the difference between audit criteria and standards?
So it may be the same. It may not be the same as well, depending on the topic that you select. So the standards that we set is the international standards or the recommended standards or the standards that are available. But sometimes by thinking that if you can't achieve those standards, especially if you don't have enough facilities, then you have to step down a bit and create a separate audit standard as well, audit standard as well. So it may be not as superior as the specific, the recommended international standard, but may be relevant for your local practice. So you have to tailor-made these standards. So depending on the setting that you have. So, practically sometimes you can't use the international standards. For an example, if you use most of the stroke guidelines, they try to do perfusion scans, MRIs these days, but practically in Sri Lanka, you can't use those things. Then you have to step down and see at least you have to use a CT scan kind of a thing. Then you have to tailor-made the settings according to your topic and the facilities that you have in your hospital.
The next question is, what are the softwares can be used for analysis of data in clinical audit?
Yes, so practically you use a small sample size in most of the clinical audits compared to research. But so you can use Excel, SPSS, all those statistic softwares that we use for research, you can use for audits as well. So no differences between the softwares that we use.
Can we use retrospective data for the audit, clinical audit?
Yeah, the simple answer is yes.
So far, the question is, those are the questions we got. Actually, we have selected the questions for the presentation. So since absence of new questions, we can conclude the session. And I would like to thank Dr. Sathyajith Ambawatte, who is connecting with us from all the way from UK, and a very early morning at 4:30, I guess.
Yeah.
Thank you, Dr. Sathyajith, for joining us with the precious day. And I would like to thank all our audience to connecting with us for our first webinar in 2022. I will hand over the session now to Dr. Omali before concluding session. Thank you.
Thank you very much, Dr. Sathyajith and Dr. Himal, for concluding this very important session. I think we all learned a lot about clinical audits and how to conduct them ethically. So I invite all of you to join us again next week with another new webinar series. Hope you have a wonderful year and blessed wishes during this seasonal period. Thank you.